welcome to OsteoBytes. My name is Christina Iktoma, and I am mom to Osteo Angel Dylan and Director of Scientific Programs for MIB Agents. And today on OsteoBytes, we are talking with Dr. Karun Sharma, who's the Director of Interventional Radiology, and Dr. Iran Kim, who is a member of the Solid Tumor Faculty and Associate Professor of Pediatrics, and they are both from Children's National Hospital. And they will discuss interventional radiology and HIFU perspectives for osteosarcoma. Thanks so much, Dr. Sharma and Dr. Kim, for joining us on OsteoBytes today. We're really thrilled to have you. And I have to say, I'm so excited for this topic because I'm excited, first of all, to learn more. And I know that you guys have a lot going on in this area as well in terms of trials coming up, which is always exciting. So before I hand it over to you, I did want to give a little bit more background and introduce our guest today. Dr. Sharma is the Director of Interventional Radiology at Children's National Hospital and Associate Professor of Pediatrics and Radiology at George Washington University School of Medicine and Health Sciences. His clinical practice and translational research focuses on minimally invasive image-guided therapies for musculoskeletal and oncology conditions, and he leads the image-guided non-invasive therapeutic energy IGNITE program. That's one of the best acronyms I've heard, which is a collaboration of the Sheikh Zayed Institute and the Departments of Radiology, Oncology, Surgery, and Anesthesiology at Children's National Hospital. And the IGNITE program aims to improve the quality of life and outcomes for pediatric patients through the development and clinical translation of novel, minimally invasive, and non-invasive surgery technologies and combination therapy approaches with the ultimate goal of making pediatric surgery more precise, less invasive, and pain-free. We like all those things. In recent years, Dr. Sharma and the IGNITE team have developed magnetic resonance image-guided high-intensity focused ultrasound, MR-HIFU, applications for pediatric patients and lead clinical trials for osteoid, osteoma, and other tumors. And Dr. Iran Kim is a member of the Solid Tumor Faculty at Children's National Hospital and Associate Professor of Pediatrics, and she specializes in sarcomas and developmental therapeutics, and her research focuses on the development of novel therapeutics for pediatric cancer, including preclinical testing of novel agents, pharmacokinetic analysis, developing innovative methods for toxicity monitoring, and clinical trial design. She serves as the principal investigator of multiple early phase trials in pediatric oncology, sarcomas, and NF1-associated tumors. So welcome to both of you and welcome to everyone joining us today. Please feel free to add any questions you have for Dr. Sharma and Dr. Kim to the Q&A. And I have just a few announcements before we get started, just because we have so much great stuff happening. If you haven't already, please subscribe to our monthly newsletter called Connective Issue. It includes info of interest to our osteosarcoma community, including recent news and papers on osteo, open clinical trials, even job postings, info about MIB events and programs, grant opportunities, and also the upcoming OsteoBytes schedule, so you don't miss a topic you might be interested in. And to make sure you get all this info delivered straight to your inbox, just go to our website and hit the Join Our Community button to subscribe. And speaking of grant opportunities, we just opened our Outsmarting Osteosarcoma 2023 application. It is now open on Proposal Central. Applications are due on February 3rd. And 2022 was the first year that we were able to award multiple grants. We were able to support 6 investigators in 2022, which was really exciting. And that's all thanks to our MIB Agents Family Funds who make these grants possible. So this year we have 2 types of grants again, the 100K grant and a 50K YI grant. And we expect to award multiple awards again this year. So you can find more details on our website. I'll put a link in the chat where you can find more info. And then we're ready to hand it over to Dr. Sharma and Dr. Kim to get started. You want to go ahead and start sharing your slides.
Thank you very much for that kind introduction. And as you said, the point of today's talk is to describe interventional radiology and HIFU, and especially how they relate to patients with osteosarcoma. And so with that, we will go ahead and begin All right, and you described our team very well. We're a multidisciplinary team that consists of oncologists and surgeons and engineers, as well as radiologists and interventional radiologists. And as you described, our goal really is to make treatment for pediatric patients, especially those with cancer, be more precise and more precise, less invasive, and less painful, and really improve the quality of life. And one of the things that falls into this category for us is the technology, which is focused ultrasound or HIFU or MR-guided FUS. There are several names for it now, but we'll describe that a little bit. But with that in mind, I would like to just describe to you that there are a lot of people, not only at Children's, but also at the NIH that have worked with us. And the Ignite team at Children's is really expanded to the Ignite program, if you will, at NIH and Cincinnati Children's and other institutions, we hope as well. And the common theme here is that we all have an interest in further developing focused ultrasound. All right. So, and I don't know how many people in the audience will know, but interventional radiology is a young subspecialty. And the way I like to think about it is that it's really a hybrid between radiology and surgery, where we sort of use the radiology aspects or the imaging aspects to perform minimally invasive procedures. And the imaging that I'm referring to could be X-ray imaging, ultrasound imaging, CAT scan imaging, or even MRI and PET scans these days. Where interventional radiology comes into the care of patients with osteosarcoma, a lot of times begins with a biopsy, diagnostic biopsy that can be performed with CT guidance or ultrasound guidance. And on the right here, you see a needle biopsy of a procedure of a patient being performed under CT guidance. And so oftentimes this is a less invasive approach, and it's a fairly precise approach in the sense that you can see exactly where you're taking the biopsy from and make sure that the needle is in the lesion. In addition to the biopsy, we often are involved with providing vascular access, such as Metaports, for initiation of chemotherapy. And then more rarely, and sometimes later in disease, we're involved with procedures such as tumor embolization and ablation. And we're going to go and focus on ablation for the rest of the talk, but I did want to mention tumor embolization. And what this is really done, it's with respect to musculoskeletal tumors and osteosarcoma, there are really two settings in which we do embolization. And one setting is preoperatively, so that we decrease bleeding during the procedure. And the other is palliatively, when we don't have other options. And this can be done to help with pain or to sort of control the pressure that's associated with large tumors. But essentially, it involves taking a small catheter or tube and putting it into the artery or arteries supplying the tumor, and then decreasing the blood flow to the tumor. And this can be done in many ways, particles or gel or coils or ethanol, many ways to do it. This is a recent example of a patient with osteosarcoma, and this was done, I believe, with palliative intent, where small drug-eluting beads that had doxorubicin loaded on them were embolized into the tumor here. But historically, more so. Today, less commonly done. But again, palliatively and for preoperative blood loss are the main two indications for embolization in the setting of musculoskeletal tumors and osteosarcoma. So with that, what is tumor ablation? And tumor ablation here, I'm going to talk about in general terms, but it is using either heat or cold to destroy tumor tissues. These are destroyed in situ, and then the body resorbs the dead tissue, leaving behind a healed scar. If we think about ablation, we have both heat and cold modalities. With the heat modality, sort of the most tried and true method is radiofrequency ablation. These are a few radiofrequency ablation probes. These are specialized needles that are designed to heat up at the end. And they have generators and cooling devices to sort of accomplish this. But here's an example of a patient with a pulmonary metastasis having a radiofrequency ablation. So here's the needle and the probe placed into the lesion. The lesion is burned, and then after some time, this is sort of the response that you see. So the tissue is never really taken out. It's sort of destroyed in situ and then resorbed by the body. Radiofrequency ablation's been sort of replaced more recently with things like microwave because of several reasons, one of which is that it's much faster to perform. Laser ablation is possible. Mostly this is done in the brain, but also outside the brain, a little less common than the other two. And then we're going to talk a lot about HIFU or focused ultrasound, which is a heat-based ablation. And then we'll talk a little bit about cryoablation, which sort of works like this, where the needles, instead of being heated, are going to be cooled and form ice balls, which then freeze thaw, and then destroy the tumor cells through that approach. This is an example of a renal tumor that's undergoing cryoablation. And what you can see here is the ice ball formation. So we have some visual feedback that allows us to basically know where the ice ball is relative to the tumor and know what is being destroyed and where. So, all right. So moving on to HIFU, and specifically in this case, MR-HIFU. I'll explain what that is. The MRI part of the MR-HIFU is a regular diagnostic scanner, and the scanner is used to both visualize and target the tumor and to plan the treatment. But in addition, unlike cryoablation or RF ablation, we're monitoring the temperature changes in real time and adjusting the treatment so that we can avoid injury to critical structures which might be near the tumor. And this allows us to have greater precision and safety while we're doing the ablation. How is the ablation done? Well, there's a transducer. In this case, there's a window built into the table, and underneath it is the focused ultrasound transducer, which generates high frequency sound waves and then focuses them into a small target. That target can be as small as 2 by 2 millimeters. And that focusing of the sound waves results in heating of the tumor tissue. So that's MR-HIFU. The focused ultrasound generates the heat, and the MRI is used to monitor and plan and sort of watch the treatment in real time. What are the effects of this heating? Well, if we heat to a certain degree, we cause cell death by coagulative necrosis. And if we don't heat to that certain degree and keep it sort of at a lower heat, that's known as hyperthermia. Hyperthermia has certain bioeffects, including leaky blood vessels and others, which can help to enhance drug delivery to the tumor and also enhance the sensitivity of the tumor tissue to radiation. There's another bioeffect known as histotripsy, which is really mechanical disruption of the tissue. And that we'll touch on towards the end of the talk as well. But that is the MR-HIFU technology and how it affects the tissues.
I'm just curious, is that machine, is the ultrasound piece just kind of like you can hook that up to any MRI, or is that like a specific MRI machine?
Yeah, that's a very, very good question. And I think this is why I show this slide here. What I was showing you in the previous slide is A here. This system is known as the Sonolive system, and it was made by Philips. Now it's a company called Profound. And these are proprietary systems so that the ultrasound transducer is usually married to one type of MRI. In this case, it's the Philips MRI. Now over here in B, this is called the Insightec system. Insightec's another company that makes MR guided systems. And in their case, originally the MRI manufacturer that they were working with was GE, and now they work with both GE and Siemens. This device here is not available in the States. It's available in China and Europe and the Far East. And that's an ultrasound guided system. So not an MR guided system, but an ultrasound guided system. So in general, to answer your question, these focused ultrasound probes are usually designed to be married to a single system. There is work being done where one would design a probe that could then be used in multiple MRI systems or even potentially multiple ultrasound systems. Now, these are sort of the older guys, the A, B, and this one here, and you can appreciate they're large units. They require full rooms, lots of construction costs and expense. However, the newer units are shown here on the right. This one here is the histosonic system, and this is called Theracleon here. Both of these are ultrasound guided systems. And what you could do is bring in existing MR or CAT scan data and sort of fuse it while you're doing the treatment with ultrasound in real time. And as you can see, these are much smaller systems, more compact systems, more mobile systems, and we hope certainly a little bit less costly as well. So let me tell you about this. So this is from the Focused Ultrasound Foundation State of the Field report. They update this every year. And really, the reason I show this is if you look on the bottom left corner, back in 2015, 2016, you can really see an inflection point where the number of clinical trials that was being performed really has increased. The amount of preclinical work preceded that a little bit, and but also is sort of mirroring the same curve where we have more preclinical work being done with systems, both clinical and research, and we have clinical trials being performed with the clinical systems that I just showed. The other part of this slide to pay attention to is that in North America, these are the FDA approved indications for focused ultrasound. You'll see bone metastases is listed and osteoid osteoma is listed. And these are the two MSK type of indications. Everything else is either in the brain or the prostate or the uterus. And so bone metastases was an indication early on to provide pain from painful bone metastases, often in patients that had reached their limit of radiation. But over time, this has also sort of substituted radiation at some institutions, along with cryoablation as well. And the last part on this slide is that if you look at Europe and Asia, South America, and the rest of the world, there are many, many more indications. Some of them are approved and some of them are being worked on, but here's what we're looking at in the US. So with that, I think I'm gonna turn it over to Erin to talk specifically about why HIFU for the pediatric patients.
So when I was initially introduced to HIFU and MR-HIFU about 10 years ago now, I was like, wow, this is like so exciting. There's this new technology now, and it's actually not even that new, but now adapted and combined with HIFU that allows for something that's non-invasive. There's no radiation. You can have image guidance that allows for precision and accuracy. There's multiple bioeffects like Dr. Sharma had described, including hyperthermia, ablation, as well as histotripsy. There's multiple flexibility, so you can actually combine it with other applications. And in adults thus far, and in some of the older studies, it's been relatively well tolerated with minor reversible side effects and no scars, no surgeries, or any of that sort. So I'm like, wow, this is like really ideal for pediatric cancer development, this technology. Wasn't as simple quite as that, but I'll explain kind of our journey as we go on. But I still, think it's something really exciting and still something that I think has real applicability for pediatric cancers. Next slide. So when we started our journey, we actually started initially, our first clinical trial was actually Dr. Sharma's study of looking at HIFU ablation in osteomas. And, that was a trial, I think, with osteomas, which are, relatively small, benign tumors that are easy to target with HIFU. But we're thinking bigger. We're thinking, how can this be applied to malignant solid tumors? And so we opened a trial of looking at MR-HIFU ablation for pediatric solid tumors. And this was done in combination, coordinated at Children's National, but also with our colleagues at Cincinnati Children's hospital medical center. And the primary objective of this study really was to look at the safety and tolerability of MR-HIFU in children with relapsed refractory metastatic or primary solid tumors. And then our secondary objectives was to look at for some preliminary tumor response, as well as changes in blood immune markers, as well as quality of life. This was the first study that was looking at MR-HIFU in particular for children in a clinical trial setting outside of osteoid osteomas. Next slide. So this was the eligibility study, and the study is now close to accrual. It was for less than 30 years of age. You had to have measurable or histologically confirmed relapsed refractory solid tumors. We actually added an amendment on desmoid tumors to be included into this population, primarily from some of the work that was done out at UCSF and Stanford in the adult population. It has to be located in close proximity to bone or accessible to MR-HIFU, and this was under the confines of the machine at the time. And then we had standard phase 1 eligibility criteria. And then basically in terms of, I'm trying to remember what. And then we really couldn't target lesions in the skull or spine. And obviously you had to be able to get into the MR machine. So you couldn't have a contraindication for MR because we use MR for thermometry as well as guidance. And then the next slide. So we, when we kind of started the study, we had this whole IGNITE team that we developed, including Dr. Sharma, myself, radiologists, anesthesiologists, the bioengineers and physicists. There was a team that we got started to start this program. And we met on a weekly basis, and we still meet on a weekly basis to look at patient eligibility and review images, and through our multidisciplinary team. And we determine which lesions can be targetable and how much of that lesion can be targeted through HIFU. And we basically plan the treatment. So here we plan the treatment beforehand. In the first slide, the patient undergoes MR-HIFU ablation of the target lesion under the sedated time for a treatable maximum volume of 4 hours treatment time. And that was put in really for as a safety measure because we didn't want to have someone under anesthesia for more than that time. During that time, you do real-time monitoring. So as you see in that middle slide, you can actually gauge the temperature that the lesion is being worked on, and you can calculate the lethal thermal dose that they're getting by the energy that we've deposited into it. And then after the end, you actually can do the MRI while the patient is still on the MR-HIFU table, do subtraction imaging and see how much of the tumor that we've actually ablated. So that red spot over there is the amount of tumor that you can see has been ablated and treated. And then we would follow the patient for 14 days post-HIFU to evaluate for any adverse events, as you would if you had received surgery or chemotherapy. And then at that juncture, the patients could go on to receive other therapies, or they could continue if there were additional target lesions and receive another dose of HIFU as long as they tolerated the first cycle. Next slide. This was one of the patients that we treated. This was actually a patient with rhabdomyosarcoma, but you can see in the beginning her lesion up there. This yellow thing on the bottom is the transducer. That's the thing that's on the table that Dr. Sharma was describing, and that could be rotated in and out and move out in order to target that focused beam onto the site. So you can see we do the treatment planning for that lesion. You can see the amount of HIFU cells that were placed in and the heating flights, and then you can see the target dosing that was received. And at the end of therapy, you can see what area was ablated from what was before. So it's a really kind of a nice system in terms of what we can achieve. Next slide. So this was data that was presented at CTOS a couple years ago, and the results of our study. We've completed our study, as I said, and now it is close to accrual, and the manuscript is currently being worked on. But currently there was a median age of 14 years, about half were female. And we had a variety of diagnoses, some sarcomas, one osteosarcoma, and mostly desmoid tumors. Again, there was a large push for desmoid tumors from the adult data that came out in terms of HIFU and desmoid tumors. And they were located in all parts of the body, although because of where we could target with HIFU at the time, they're mostly extremity, flank, and pelvis, and all patients were all heavily pretreated, had received prior therapies. Obviously, this was a phase 1 study, so it was open to relapse and refractory patients. Next slide. We did a total of 17 HIFU treatments, so 5 patients received more than one ablation treatments, and only 2 treatments were considered technically not feasible, meaning we couldn't get enough energy. The tumors were either too deep or there was obscure from bone or other structures that did not allow us to deposit enough energy to get the temperatures we needed to ablate the tumors. But overall, it was actually quite well tolerated with some minimal reversible grade 1 toxicities that are known, including edema, some pain, paresthesia, some grade 1 skin burns. It really looks kind of like you sat out in the sun for too long. We did have one patient with a lesion that was very close to the skin, that was very large. It was a desmoid tumor that did have a grade 3 skin burn, and that was the highest complication at the time. But again, these are known AEs of the HIFU instrument. So what we found, though, was that, we were able to completely target and ablate one lesion completely, which is kind of what we want in terms of the principles of sarcoma therapy, right? We want to be able to get the whole thing. But unfortunately, all the other lesions were only partially ablated. The majority of the patients were desmoid tumors. And if anyone knows anything about desmoid tumors, they are very large, irregular shaped, they're heterogeneous, they're very infiltrative, but so are many of our sarcomas. So I think in that way, it's not significantly different, especially when patients present with these very large tumors. And we also found that RECIST measurements were very challenging with ablative therapy because you're actually causing tumor death. To measure like lengthwise when you have the tumor is ablated is actually very difficult. So we're actually evaluating volumetric analysis for that. But because of this partial ablation, meaning that we can only target some of the lesion, and unless they're of certain size or certain things, we needed to think of other ways. So next slide. So we really did conclude that, ablation appears to be safe and feasible when we can do it. When we can do it, it's great. But the majority of tumors could only be partially ablated, and that's primarily due to the location and size of the tumors. And some lesions are not targetable because they're next to vital structures. So when you're thinking about ablating something to over 55 degrees Celsius and causing coagulant necrosis, if it's right next to a nerve, that's concerning because you may have off-target heating that can cause nerve damage. There's also other vital structures like blood vessels that may or may be used to your advantage, but again, is something that may not make the lesion completely targetable. There's artifacts, so patients with osteosarcoma, if they have localized recurrence and they have prosthesis, it's difficult to do MR because you can't visualize the lesion well, and you can't do thermography. And so those patients end up getting excluded. And then there's positioning. So these instruments, when Dr. Sharma showed them to you in the beginning, were really kind of invented and made for the body's instruments were made for uterine fibroids. They have a nice flat plate where you can lay flat down, and then you can target. Where we have patients with a bone or a hand or a leg tumor, and you have to actually position the patient onto that table, into that little window where the ultrasound is. We got pretty good at it, to be honest, and we figured out inventive ways to figure it out, putting the gel pad on, coming up with other ways to get the coupling that you need for the ultrasound. But that was some of the challenge. And the other real kind of challenge is that many of our patients unfortunately present with metastatic lesions, and our metastatic lesions are in the lung. And the HIFU is not, because it's ultrasound based, using sound wave technology, you can't really run it through air. So that's a problem because you can't HIFU lung lesions with the current system that it is. So we had to think about these things. And so I'm going to turn it over to Dr. Sharma to talk about some of the challenges and then how to address some of these challenges with our current setting.
Can I just ask a quick backup question, just because up front there were a few heat options, right? There was the RFA, there was the microwave, and the laser. And I think this is focused more on HIFU. So I just wanted to back up and kind of say, of those 4 options, why focusing on HIFU and why aren't the other ones as applicable?
So the one advantage about HIFU is that there's no probe. So there's nothing that you have to stick in, and there's no probe that is. So RFA, although, and I'll leave it to Dr. Sharma to explain more, you're at size the limitations in terms of what the probe can access and how much volume you can give. So HIFU allows for large volume ablation. The other thing with microwave heating is that that's surface temperature. So that's been used in some of the like metastatic breast cancers with that are surface lesions, but it really only heats, it can only penetrate so deep, whereas HIFU has much more flexibility in terms of depth as well as volume.
Yeah, so that is a good question, and I think you were mentioning earlier that someone was going to be joining us and had undergone a lot of cryoablation, and I imagine that is probably from pulmonary nodules, metastatic pulmonary nodules. So in that setting, HIFU would not be applicable, but cryoablation would be applicable, and so we have treated patients with metastatic lesions with RFA and cryoablation as well. And so that's also much more commonly done in the adult institutions as well. So very good question, and we're going to get back to the cryoablation towards the end of the talk as well. But in terms of the challenges that Erin mentioned that we have encountered, I showed you that one picture of the next generation of MR system. I think, currently what's out there is cost prohibitive and limited in availability. And we were talking about that just before the seminar as well. It's not available everywhere, but I think as we get to ultrasound guided systems, as we get to smaller and more portable systems, and we get to a system that can provide all of the sort of the range of bioeffects in one device, meaning you can go from hyperthermia to thermal ablation to histotripsy, then I think it makes a lot more sense, and that those are all on the way. The other thing is that, that transducer, as Erin mentioned, these first generation systems for the body systems were designed for uterine fibroids. We need to get that transducer out of the table and be able to put it wherever we need to put it. And that's also something that's currently being worked on. But those are all limitations of the equipment. They may be limitations of where the tumor is located, right? But there's still limits of thermal ablation overall, whether it's cryo, RF, microwave, HIFU, or laser. There are limitations to all of these things. And so we sort of thought about that. And I think ablation is great for benign disease. Ablation is also great as a non-invasive way of local control in malignant disease. But when you have malignant disease, we feel that you will probably need more than ablation. And what is more than ablation is looking at combination therapies with ablation that is, as Erin's going to talk to you in a little bit, combined with smart targeted chemotherapy to the tumor, or ablation combined with radiation to decrease the dose that's required to sensitize the tumor prior to radiation, or sort of something that's more up and coming and exciting to us is how to use the ablation to modulate the immune response. So specifically in terms of osteosarcoma in HIFU, there's actually, if you look back in the literature, there's 4 or 5 references that are there. This paper is from Radiology in 2010, where you can see it was a total of 80 patients, predominantly with osteosarcoma. The majority had osteosarcoma. And at that point, this paper was actually, it created some controversy, and it was a debate. The reason was that this paper and the research was done in the East, in China, and here the West really criticized it because it seemed as though some of the patients were not being offered the standard of care treatment, which was chemotherapy and surgery. So, they were sort of substituting HIFU for surgery. Now, a lot of these patients did get chemo, but they, in the West, would have gotten surgery. So it created a little bit of controversy. The paper on the right now is, I think, a little bit, this is first one is 2010, this is 2015, and this is the right population to study this in. These are patients that all have recurrent and, as judged by the surgeon, unresectable osteosarcoma. But what's encouraging from both of these papers is that in these papers, again, it's a culmination of 27 or 80 patients, and it would be good to get the detail on a patient-to-patient basis. But there are some very durable effects from the ablation. Some of them are combined with chemotherapy, but 3 years later, if you ablate a tumor that looks like this, and 3 years later it looks like this, that's a pretty good response. These are showing lesions that were recurrences that couldn't be resected. And again, this one was very short-term imaging follow-up, 6 weeks or so, but it shows that the lesions are shrinking very early on. So the reason I say that is that this was done 10, 7 to 12 years ago. Technology is improving. We are now, I think, Aaron and I are in the camp that that probably ablation alone isn't enough, and we're going to have to combine with other agents, whether it's chemotherapy or immune therapy. And so that's something for us to keep in mind. Now, here is, we both were at the focused ultrasound meeting a couple of weeks ago, and some of the most exciting work in our field that I think a lot of people, there was a lot of excitement, is that dogs with osteosarcoma, patients, not animal models, but pets, were being treated with HIFU. And this paper was an earlier paper. It only had one dog with osteosarcoma, but they presented their work now on 10 dog patients with osteosarcoma. And what was the most exciting is, yes, you get the local control, but in these patients, they looked at both after resection, whether immune cells were penetrating the tumor and whether there were signs of immune activation in the blood distance to the tumor. And it certainly seemed like that is what's happening. And I think it's exciting because we may be able to take some of this information, and again, it's not going to be as simple as just translating it, but some of this information may help us when we move on to treating patients with osteosarcoma as well. And what I wanted to do in the next couple of slides is just tell you about the work that we had done in our lab. Dr. Aranki carried out most of this work, but this was using neuroblastoma, and it was advanced neuroblastoma in mice, and basically looking at the combination of HIFU, specifically HIFU histotripsy, and dual checkpoint inhibitors. And what I would like to call your attention to is down here, when you have the dual checkpoint inhibitors, the effect is not so good. But when you add BH here, in this case is boiling histotripsy, you really do see a significant improvement in survival. And Avinash took that a step further and looked at not just unilateral tumors, but bilateral tumors. And it really seemed that if you were to treat one side with histotripsy, combine it with the dual checkpoint inhibitors, if the animal had distant tumors, say, for example, a tumor on each limb, the other limb also shrank. And so the idea that the immune system is being activated was something that is highlighted here. We're not the only ones to show this. Other people have shown this as well, but this seems to be consistent. Now, this was in neuroblastoma, and currently what we're doing is trying to figure out this holds true both in rhabdomyosarcoma as well as osteosarcoma as well. So that's where we are with the preclinical stuff, but I'm going to turn it back to Erang now to talk about where we are with our clinical trials.
Thanks, Karun. So again, some of the things that we had to address is like, hey, we're not getting all the things that we need to do. And this is not going to be the only form of local control if we really want to do a complete control of at least the regional area. So we're thinking about what do we do? How do we combine this with smarter therapies? So this is some of our next phase of clinical studies that have been ongoing. So right now we have a phase 1 study looking at Thermodox, which is a lysothermosensitive liposomal doxorubicin, and MR-HIFU for pediatric solid tumors. And LTLD is an activated formulation of liposomal doxorubicin. And we know that liposomal doxorubicin is an important chemotherapeutic agent for many pediatric solid tumors, including osteosarcoma. But essentially what happens is that you give this LTLD systematically, like you do any chemotherapy, and it's encapsulated with this thermosensitive formula. And then once an area is heated, the liposome releases the drug. And so the thought behind is that at the site of where the heating is given, the most concentration of the drug is in that area. And in preclinical models, it can be upwards of 8 times the concentration. In some of the adult early phase studies, it's about 3.5 times the concentration of doxorubicin. And the thought behind that is that you can give even more dose intensity with sparing systemic toxicity. So the next slide. So this is a a little bit about Thermodox. It's been evaluated in many different systems, including hepatocellular carcinoma with RFA, which is the radiofrequency ablation, and then also with recurrent chest breast wall with microwave heating. So it's not that it has to be with HIFU, but it's with some sort of heating mechanism. There was a phase 1 study, it's called TARDOX, with this LTLD and ultrasound guided HIFU for liver tumors that was published a few years ago. And they used the adult recommended dose of 50 milligrams per meter square. And what they found was that there was a 3.7 times increase of doxorubicin in the intratumoral biopsy after receiving LTLD. So far, about 1,300 patients have been treated with LTLD. The dose-limiting toxicities are very similar to what is known for doxorubicin, which is myelosuppression. And then there is rash, erythema, induration, and superficial cancers, which is primarily the chest breast wall cancers. And then there's other toxicities, including other myelosuppression, alopecia, fevers, fatigue, nausea, and decreased appetite. Again, very similar to the doxorubicin profile. Next slide. So our trial consists of getting LTLD over 30 minutes on the same day as they're getting MR-HIFU ablation immediately following afterwards. And then after on day 2, you do get a myeloid growth factor, and then you end up evaluating it on day 21. So the thought behind giving MR-HIFU ablation after LTLD is that the heating, the peri margins of ablation therapy is where the heating effects would be, where even though you might not be able to get the complete surrounding of the lesion, that the surrounding sounds would be treated with the LTLD, thus giving a more complete coverage of the regional area. So next slide. So this is a patient with osteosarcoma that was enrolled on our study. He had a scapular lesion. And so this is some of the treatment planning that was done. And you can see the cells. This is kind of where we're going to deposit the energy and heat the tumor to grab the energy in terms, and this is after giving the LTLD. The next slide. And so if you can see here, this patient, all the cells that were replaced, and that's the heating that he received into the tumor that was, to the large scapular recurrent tumor that he had. And then I think the next one, and this is post-HIFU ablation. You can see the area that was treated with the ablation, but you can see that there's still tumor that's surrounding that bone. And the peri-ablative area is where we hope that the LTLD would affect in terms of depositing the chemotherapy to provide for more complete coverage.
And is the idea that you would give with the Thermodox, is it like a so let's say for MAP that's used for osteo, would the dosing be comparable to let's say with MAP, but that then you would just hope that there's a higher dosing going to the local area, or is it to reduce the dose? And
so the dosing is equivalent to similar to what Doxil would be, because it's liposomal doxorubicin instead of like the doxorubicin. But the idea is, yes, you would give like the systemic dosing, but the higher concentration would be at the local area. So obviously HIFU with LTLD is exciting, but it still has its own limitations, right? So we overcome some of the limitations of ablation in terms of the treatment zone and maybe incomplete treatment for the regional area. Accrual has been a challenge on the study. We are expanding the study, and now the new kind of next generation of this study is going to be MR hyperthermia. So this is an application that is now available through research to allow for large volume heating, not to ablative temperatures, but to that 40 to 45 degree temperature where we can cause a favorable effect, so that most of this effect will be drug deposition rather than tumor killing through just coagulative necrosis. And this will be in combination with ablation if feasible in patients greater than 12 years of age using the adult recommended dose at 50 milligrams per meter squared. And we would provide MR hypothermia for at least 60 minutes for a target temperature of 45 to 45 degrees, followed by ablation if feasible. And that's to enhance the vascular shutdown and like really create a local drug depot so that you're having more drug at that site. This trial is currently open for enrollment. And so we're hoping with this, we can learn more about hyperthermia applications with LTLD. Again, this doesn't really address some of the other limitations that we have with MR-HIFU and in terms of metastatic sites, or looking at areas that we cannot MR-HIFU. And I think this is really kind of where some of the exciting therapies may come with immunotherapy. And some of the preclinical work that we're doing now, in particular, looking at the dual checkpoint inhibitors with HIFU and all different kind of bioeffects, including histotripsy and ablation in our rhabdomyosarcoma and osteosarcoma murine models. And so those data are pending. But with that, I did want to just introduce a trial that is being led by my colleague here, Dr. Nelson, looking at cryoablation, since we're doing a IR guided talk, another type of ablative therapy with dual checkpoint inhibitors. And the principles are the same in terms of what we think is happening in terms of cryoablation. It will enhance the immune response, basically present antigens and make, the thought behind it is making these cold tumors, which we think is osteosarcoma, into a hot tumor. We know that cryoablation is already approved in many instances. It's safe and it can provide curative and local control to solid tumors. And we know that it creates a favorable tumor immune microenvironment. So hopefully increasing the efficacy of immunotherapy, because alone we're really not seeing improvement with immunotherapy alone in our pediatric solid tumors, including osteosarcoma. Next slide. So this is just the primary objective of the study is to look at disease response with nivo and ipi when given prior to. So we first give the checkpoint inhibitors, and then we follow with cryoablation therapy for patients with relapsed refractory pediatric solid tumors. And there are three main cohorts: one osteosarcoma, one Ewing sarcoma, and one rhabdomyosarcoma cohorts. We also have a cohort for other tumors that may not fall into these three sarcomas. And then we're also obviously looking at safety and toxicity of this combination, and then exploring the changes in the immunogenicity in the blood and the tumor, as well as exploring patient-reported quality of life outcomes. Next slide. And this is a key exclusion criteria. One has to be less than 40 years of age. You have to have a histologically confirmed solid tumor. And what we're looking for is at least 2 measurable target lesions, and then one of those target lesions has to be amenable to cryoablation, because again, we can't really use RECIST criteria in a lesion that's already been ablated. And what we're really trying to see is whether or not we see any abscopal effects. So are we seeing from the immunotherapy any changes in other tumors from treatment of the cryo treatment of another tumor? They must have recovered from all prior therapies, and then standard phase 1 and 2 eligibility criteria. And basically no known brain metastases or left meningeal patients are eligible for the study. Next slide. This is a treatment regimen. Essentially, you will get the nivo-ipi on day 1, and then cryoablation sometime from days 3 plus to 15 on cycle 1. And then you can continue on nivo and ipi as long as you are having disease control and tolerating the therapy. So I think in summary, we wanted to state that interventional radiology, I hope that we've shown, is a key player in the multidisciplinary approach to osteosarcoma and pediatric cancers, really from the diagnosis in terms of helping in terms of biopsies all the way to the treatments. We are working on focused ultrasound and other ablative methods we think has the potential to augment current local control therapies, and that really the future really is thinking about combinatorial approaches using various bioeffects of focused ultrasounds in the current and future directions. That so includes smart ways of thinking about it with chemotherapies, as well as targeted therapies and immune therapies. And we currently have ongoing preclinical and clinical applications, and we hope that this has the potential to change the way we think about treatment paradigms in pediatric cancer medicine. And with that, I'd like to just thank all the patients and families, the team at Children's. It's been a really, really great experience working with all the folks here, the team at the NIH, our colleagues at Cincinnati, Profile and Celsion, and then our funding mechanisms. Thank you. And this is our contact information. Please, if there's any questions, we would love to hear from folks as well.
Great, thank you. That was such great info. And anyone have any questions, please feel free to put them in the Q&A. so we can make sure we direct those to Dr. Kim and Dr. Sharma. But a couple questions to start with. For the ablation, actually for both HIFU and the cryoablation, is like how much of it is kind of an immediate effect and how much residual effect is there? So when you ablate something, at like what point do you kind of continue to measure the effects of the ablation?
Karun, if you're speaking, you're muted.
Sorry. I can talk a little bit about the immediate effects in terms of pain relief. That's really the most immediate effect that we're going for when we're talking about bone tumors and osteosarcoma specifically, and also with cryoablation. It tends to work very, very quickly. With bone tumors like benign osteoid osteoma, but also metastatic bone painful tumors, HIFU works very quickly as well. What is very quickly? Usually within 1 to 3 days. Radiation takes a bit longer. So if the indication is palliative pain control, both of these modalities tend to work within 1 to 3 days. In terms of looking at other things, not pain related, tumor shrinkage, for example, immune effects distant to the tumor, abscopal effect at other sites. That, of course, we would monitor for much longer. And, in our studies, we would be looking and following patients on one side for almost out to a year, and on the other side for malignancy as long as we can. But that's kind of my view on how the follow-up works.
Yeah, and we don't know all the answers to that quite yet. So we can see, you can get an immediate response in terms of what we see as ablated, right? Like you saw some of those pictures. So right at the end of HIFU, you can actually do this. We do this post HIFU scan, and you can see what's been ablated. But whether or not that's sustained is the big question. And we've seen some tumors that have grown back in, and we've seen some that have been more persistent. I think that really is a matter of whether you get complete ablation or not, because we know we have to get all these lesions. For our the sarcoma, the malignant studies, we follow similar to we do with other early phase studies. So we scan at the 2 week to 1 month mark, and then depending on how they do, we continue to scan every 3 months to look at a response. And the same thing with the cryoablation study, very similar to what we are doing for other early phase studies. So I think a lot of that is still to be determined in terms of what we see. And ideally, obviously, we would love if we could find any abscopal effects based on some of the local control targets.
Mm-hmm. And you had mentioned that in one of the studies, patients had gotten more than one ablation. Mm-hmm. And so kind of what's your decision point for that? Like, at what point do you determine like, oh, we need to do another one, same location?
So many of those patients were patients with desmoid tumors, and it was just a lot of the tumors were such large volumes that they couldn't all be done in one setting. So you, in terms of being able to safely ablate a lesion, it just was not possible, that volume to be done at like the 4-hour time setting. We just couldn't be done. So some of the patients had secondary to kind of provide a more complete treatment to their desmoid tumors. We did have 2 sarcoma patients that had multiple lesions, so 2 different spots that were both amenable to HIFU. So after one spot, and the reason, again, this was based on a decision, a team decision of which target lesions that we selected. And typically what we selected was the ones that were most painful or had some clinical symptoms, because those are the ones that we'd want to try to get at. And also they had to be something you could HIFU. So unfortunately, if they had like a vertebral lesion that was next to their spine, that's not something that was not eligible for HIFU at the times of the study. So for those patients, when they had more than one lesion that was HIFUable, we would target one side, and then we would see them at least for 2 weeks. And then at the 2-week period, if they were tolerated the procedure fine and they had no adverse side effects, they didn't have any burns or fevers, or all of it had recovered, then they were eligible to get the other treatment, HIFU, as well.
I liked that term, HIFUable.
I just made up a new word.
Yeah, but that works. So I think one of your earlier slides, you had talked about I think was it was it the hypothermia? It was basically where it would kind of make it potentially more responsive to either drug or radiation. And so I'm curious, is there ever any circumstance where HIFU is used like prior to radiation or to prime it for radiation?
So I can take that one. We're trying. A lot of people are interested in this. There have been many studies, if you look back in the literature, some not so recent, where we have combined hyperthermia with radiation. The difference is that we haven't used the current devices to do that. In other words, MR-guided HIFU hyperthermia is not something that has been studied widely. But there are several groups in radiation oncology that are interested because we know that this sort of hyperthermia or heating or preheating the tumor sensitizes it to radiation to allow for lower dosing. But that has been shown with other extracorporeal devices. There was a microwave device, there was sort of a warming of a limb kind of device, but those didn't have quite the control, if you will, that we have with this particular technology. So a lot of people are interested in doing that work right now.
We just got a question about in the case of pulmonary metastasis, is it possible to use ablation under MRI control when the patient has an endoprothesis? And how many pulmonary metastases can be treated?
Yeah, so the first part of it is that if someone has a prosthesis that is not MR compatible, then the answer would be they could get ablation done, but it would be under CT guidance. And in the lungs, to be honest, CT guidance works very well. So yes, it can be done. How many can be treated at once? Very wide range. It would depend, I think, a lot on the patient and the person doing the procedure. But, you know, time under anesthesia becomes a factor in that. I think in general, one could think about in more adult patients doing something in the range of 3 to 6 at a time. I'm sure there are people who've done more than that. I'm sure people have done less than that. But I think looking at the time it takes to do cryoablation, and there are, by the way, MR-guided cryoablation systems that are there. Stanford, for example, has one, and they're using it very frequently now. It was just installed there about 2 years ago. But to answer the number, there's going to be variability, and it's going to be dependent on a lot of factors, including the operator, the size of the lesions, the location of the lesions, and so on. I hope I answered that correctly. But I mean, yes, the answer to your question is yes, if you have a prosthesis, you still can have cryoablation. Depends on whether or not if it is MR compatible, how much artifact it causes and that sort of thing. But most of the time, if you have one in the field where you're going to be doing the cryoablation, you're probably better off going with CT guidance.
Great. And we're almost at time, but I just have to kind of add in this one other question, because I think you guys have touched on this actually throughout, but just if maybe a quick summary, because I think often what happens in the clinical setting is that you have, you know, an unresectable tumor, and then you're like, do we do radiation? Do we do cryo? Do we do HIFU? And so you have touched on some of the considerations, like HIFU doesn't work for lung mets, for example. So that's where cryo would come into play. So I guess location, I guess, is a consideration. Just if you could quickly summarize kind of the considerations for determining, like, whether radiation, cryo, or HIFU would make the most sense.
So, I mean, I think in terms of HIFU, it really has to be on a clinical study right now for most patients, and depending on where they're located. And there's only so many systems around. So I think part of that will depend on where you're at and whether that's a treatment that we can approach in that way. I think also the same thing with radiation, it really is where it's located, what can we do, how much can you give? Because if it's, again, osteosarcoma is, we have radiated pulmonary nodules. We can do it in a palliative setting, but there's only an upfront setting. That's not typically what we would do. And so I think a lot of this will depend on where we're at, where it's located, what's feasible, and located in the body, where it's located, what's feasible, what organs are next to it. And then really, just like everything else in medicine, the best care for sarcoma, I really think comes in a multidisciplinary setting. So this means we really need to talk in the same room with a radiation oncologist, our interventionalists, our surgeons, the oncologist, the medical team, and say, hey, how is this the best way for this patient to approach this?
Yeah, I completely agree. I mean, I think these are questions that not all of us working alone would be able to come up with the best answer for. But, that's why we have our multidisciplinary sarcoma clinic or multidisciplinary tumor board. And that's often where everyone sort of gives their opinion. And then you talk about it and say, okay, well, the best option is X, Y, or Z.
That makes a lot of sense. Well, thank you both so much. Great information. Really appreciate both of you joining us on OsteoBytes today and for making it better for pediatric sarcoma patients everywhere. More information on this and all OsteoBytes can be found on YouTube, on our YouTube channel, on our website at mibagents.org, and at your favorite podcast place. Next week is the third Thursday of the month. So that means instead of OsteoBytes, we're going to be dropping another episode of Osteo. And that's our AYA podcast where MIB agents, junior advisory board members spill the tea on dealing with osteosarcoma from an AYA perspective. And in next week's episode, osteo warrior Mia and her mom Serena have a frank conversation with orthopedic oncologist and osteo survivor Dr. Kurt Weiss from the University of Pittsburgh. They discuss questions parents and caregivers often have about osteosarcoma but are afraid to ask. So check it out on our website, and that will drop next week on the 17th. And then we're going to skip a couple of weeks because of the Thanksgiving break, and because we are going to be in Houston for our mingle with the Houston osteo community on November 30th. And we're going to be visiting Dr. Annie Livingston at MD Anderson on December 1st with our family funds to get an update on his outsmarting osteosarcoma funding research. And we'll return with the OsteoBytes on Thursday, December 8th, when we're going to be talking to Dr. Michael Leibowitz from the University of Colorado. And Dr. Leibowitz is an Outsmarting Osteosarcoma 2022 grant recipient. And he's going to be talking to us about cell-based therapies for osteosarcoma. You can find our OsteoBytes lineup for the next couple of months on our website. We actually do have Dr. Marie Nelson coming up, I think in February. She's PI on the cryo with the NEVO and IPI trial that Dr. Kim was mentioned. And so, yeah, well, make sure you keep an eye out for that. And thank you, Dr. Sharma and Dr. Kim, for spending an hour with us today. And thank everyone else for joining us today on OsteoBytes. And we'll see you in a month. I can't believe it's going to be that long, but see you back here on December 8th when we talk to Dr. Leibowitz. Thanks, everyone. Thanks, Dr. Sharma. Thanks, Dr. Kim.
Thank you.
Thanks for having us. All right, bye.
Bye.